So one of the big questions today in Hodgkin's lymphoma is there still a role for allogeneic transplant? And of course you'll say that I'm biased because I've been doing allogeneic transplant for 20 years, but at the end of the day I want to do what's best for the patient. And so what we have in Hodgkin's lymphoma is really a unique situation where in the last decade we've had two significant advances in terms of therapeutic options. First we had brentuximab vedotin, which was a game changer, and then we had the checkpoint inhibitors, a second game changer. And so there are very few diseases where you have two new drugs that appear on the scene that are so active, relatively well tolerated, and really change the whole treatment paradigm. And we're even talking in some settings of so-called chemotherapy-free treatment for Hodgkin's, where we would combine brentuximab vedotin and a checkpoint inhibitor. And those trials are ongoing now in the relapse setting, but eventually we may even see that as frontline. Now there may be some financial costs associated with combining two new drugs, and that's something that we'll have to figure out. But back to the question of allogeneic transplant, where do we stand today? And I think Ana Sureda from Barcelona, who works closely with the EBMT, has looked at the numbers for Europe, and it's very similar in the US, and she's shown very clearly, I think, two important facts. Number one, the number of transplants for Hodgkin's lymphoma were going up, and then they've dropped suddenly over the last 3 to 4 years. So there's really been an increase in patients getting an allogeneic transplant for Hodgkin's. And that's true to some extent for lymphoma in general, but I think more dramatic in Hodgkin's, and it reflects these new and very effective drugs. It means less patients are actually referred to allogeneic transplant. Number two, what she also presented at EHA a couple years ago, was that the survival in Hodgkin's lymphoma has gone up significantly over the last decades. And there the question is, and what I mean by that is the survival with allogeneic transplant. So we've gone from being around 40% outcomes to 60, 70%, maybe even higher. And so the question is what's driving that, because we don't really have any other disease where allogeneic transplant has improved that dramatically in terms of outcomes. I wish that we did, but it's not the case. And so the EBMT has done a couple of studies in that regard. They looked at the impact of brentuximab vedotin, and they had one study that showed that in the era of brentuximab vedotin, outcomes in allogeneic transplant were better than before. So you could say maybe it's all driven by the drug. But then they did a second study where they compared patients who had received brentuximab vedotin before and those who didn't, and there was no difference. So it reflects a change in something else, but not the drug. Maybe more patients get to transplant because of the drug, but we can't see how the drug is still impacting transplant. On the other hand, with checkpoint inhibitors, we haven't done the same studies. But what we have done is we have now some experience in patients who've received checkpoint inhibitors and then have had an allogeneic transplant, and particularly in Hodgkin's patients. So there's always been a concern about doing an allogeneic transplant after a checkpoint inhibitor, because what the checkpoint inhibitor is you're basically taking the brakes off the immune system. And in an allogeneic transplant, graft versus host disease, the immune reactions is one of the main causes of complication. So the idea that you would take the brakes off the immune system would lead you to think that graft versus host disease is going to be even worse. And so we have two papers that sort of address that issue, and what they tell us is the risk of graft versus host disease is not higher. There is slightly more severe graft versus host disease, but there are also other immune reactions that require patients to get steroids, and such that the number of patients who actually require steroids is higher. But what we don't see is a higher increased risk of death as a complication of that. So that gives us, a safety signal. And more importantly, in Philippe Armand's paper this year, actually last year in JCO, what he showed was in patients who were on a trial and who got a checkpoint inhibitor, in this case nivolumab, and then had an allogeneic transplant, the survival of those patients was fantastic. I mean, we're talking about 80 to 90%. So I think what these drugs are doing, even when patients are progressing on the drug and then being referred for the transplant, they somehow are still affecting the outcome of the transplant. And so I think we need to do the same studies that EBMT has done in brentuximab, with or without for allogeneic transplant. I'm convinced that if we do those studies in patients who had an allogeneic transplant with prior checkpoint inhibitors, that will actually show that effect, that it continues to influence the outcomes in a positive way and improve the outcomes. So what I'm telling physicians is, if you have a patient with Hodgkin's lymphoma and they've relapsed after an autologous transplant, the first thing you should do is put them on a checkpoint inhibitor. And if they respond and they're doing well, you just keep them on it. In some cases, after a while, we actually stop and observe them. But if they start to progress, then you should refer them to an allogeneic transplant, because I think we can do it safely, and I think we can actually give them very good outcomes.